Okay, so this is module 2.3. Go ahead and get started with flank pain. So our HPI, we have a 45-year-old male who presents with right-sided flank pain starting 2 hours prior to arrival. Pain is sharp, radiating around to his groin, 10 out of 10. It's associated with nausea, vomiting, and fever. Denies any trauma. Nothing makes it better and nothing makes it worse. So as you can see, this format, as we've gone over in the past, the QRSS format for HPI. The quality is sharp, R is radiating around to his groin, S is severity, which is 10 out of 10, and the last S is for symptoms, which is nausea, vomiting, and fever, denying any trauma. For thoroughness, past medical history on this patient, none. Past surgical history, cholecystectomy in 2010. Medications, naproxen. Allergies, there's no known drug allergies. On review of systems, no urinary incontinence or retention, and a 14-point review, all negative except for the HPI. On physical exam, we have vital signs. Pulse is 110, which is tachycardic. Blood pressure 140/90. It's a little bit hypertensive. Temp is 37, normal. Respiratory rate is 16 and regular. You can have 16 and regular. You can have 16 and labored. So the R is actually something that sometimes we will add as far as how the patient is as far as respiratory distress. Pulse ox 99% on room air. So in general, this patient's uncomfortable and moderate distress. Abdomen is soft. There's right lower quadrant tenderness to palpation. There's no rebound, guarding, or rigidity, which we've gone over as far as peritoneal signs. If someone has a surgical abdomen, these are the three symptoms that we document, or the three signs that we document on physical exam. Rebound is where we actually press in on the abdomen and release, and we see if they have any tenderness. Guarding, there's two types of guarding, involuntary and voluntary. Voluntary guarding is when the patient actually grabs over our hand when we're palpating the belly and guarding their abdomen. Involuntary guarding is when we actually palpate the belly and their muscles contract underneath our fingers, which is an involuntary sign. And then rigidity is if they have basically the abdomen is completely stiff as a board. It indicates some sort of peritoneal irritation. Could be a ruptured appendix, ruptured diverticulum. Typically these three signs are good indicators of surgical intervention. And patient has good bowel sounds. Back exam, patient has right CVA tenderness. CVA is the costovertebral angle. So this is essentially the costo is the rib muscles, vertebral is your vertebral column of your spine, and the angle is at where those two intersect, which is essentially right over the kidney. So when we're doing CVA tenderness, we do some percussion where we kind of do a little tap or pound on the patient's flank, and it should elicit pain if there's something potentially going on in the kidney, because the kidneys sit in the back of the retroperitoneal, or they sit in the back. So when we're percussing and we're actually using vibration, it'll actually shake the kidney and cause pain if there's infection or stone. Skin exam, there's no rash. Patient's skin is warm and dry. So formulating a differential on this patient, we're thinking obviously there was some CVA tenderness. Patient's pain was pretty intense, and it kind of radiated around to his groin. So things that we would be thinking of as physicians would be kidney stone, pyelonephritis or kidney infection, appendicitis, AAA, rib fractures, or muscular strain. Further down your differential, obviously less acute. This diagram shows essentially how we can get some tunnel vision sometime when we're dealing with flank pain and only think of urinary complaints or kidneys. So the aorta actually sits right in front of the kidneys, and the vessels that come off of the aorta obviously to supply blood supply to the kidneys. So when we're doing some CVA tenderness or they're complaining of flank pain, it's real easy to be misled and kind of fall down the path of the genitourinary system. But in elderly patients, even some younger patients, we have to keep in mind that an abdominal aortic aneurysm is definitely in the differential and something that necessitates being ruled out in this particular patient population if the suspicion is there. So lab work. This patient's CBC, his white blood cell count is 16,000, which is elevated. Bands are 30%. These are a sign of immature white blood cells that come out of the body. White blood cells are consisted of different types of cells. There's eosinophils, there's neutrophils, and then there's bands. And a normal bandemia or band count should be less than about 10 to 15%. So if you have anything more, which this is indicating 30%, it means that these little immature white blood cells have gone out into the bloodstream and are starting to fight hard, and they're not even ready basically for battle. They're immature. So bands sometimes may not show up as a red abnormal value. So it's something to be noted if the band count is higher than 10 to 15%. It's something that can clue you in that there might be something a little more serious that may need to have a second look at. A BMP obviously is important with kidney function. The BUN and creatinine are functions of the kidney, which are within normal limits. Urine analysis is positive for blood, positive for nitrites, and positive for leukoesterase. So I like to think of in particular kidney stones. Think of it as almost like a softball coming through a garden hose. If you're trying to push a big stone through the ureter, which connects the kidney to the bladder, you're going to shear off some red blood cells and you're going to get some microscopic blood. This not only can be, it's not specific at all. It could be with a kidney stone. You can get blood with urinary infections. You can get it with pyelo. You can get it with appendicitis even. So positive nitrites, this is indicative of some sort of infection. Positive leukoesterase is essentially just white blood cells, which can happen in a lot of different cases, not very specific. Urine culture, obviously pending. Radiology, CT abdomen pelvis with no contrast. So in this particular patient, we did a no contrast study because there was a suspicion that it could possibly be a kidney stone or it could be a pyelo. And if we use contrast with a CAT scan of the abdomen and pelvis, the contrast can actually mask the stone. So you do not want to use contrast when you're looking for a kidney stone. So in this particular patient, perinephric stranding around the right kidney, consistent with pyelonephritis or kidney infection. So perinephric stranding is just perinephric is around the kidney, and there's some stranding or some strands of like infection that are kind of encompassing the kidney. So some documentation, pearls, utility of x-rays and flank pain. There are some kidney stones which are radio opaque, and you can actually see them on KUB or an x-ray, and it may save the patient on radiation and time. So documentation is key. If we have a conversation with a patient that is initiated about the risk of CAT scan radiation and future malignancy uncertainty, please document that physicians talk with the patient stating that they've had multiple CAT scans in the past. We don't believe it's warranted at this time, and there may be a risk down the line of all these CAT scans with possible cancer malignancy. So it's very important to document if this conversation is had between the physician and the patient. So in this particular CAT scan, you can see that on each side of the vertebrae, which is the spinal column right in the middle, that very bright white density, that's the spine. If you look to the left, which is actually the patient's right, you can see that enlarged kidney, which is essentially looks like almost like a horseshoe, and there's some black darkened areas, which is fluid or hydronephrosis, and it's obviously a lot larger than the kidney to the right of the vertebrae, which is actually the patient's left. So this patient has a right pyelonephritis. This picture is just a demonstration of actual kidney stone. As you can see, it looks like a small cauliflower-like mass. It can be about a quarter the size of a dime. If kidney stones get to about 5 millimeters, they're very difficult to pass. But with the advent of using Flomax and some other modalities in the emergency room, we've seen stones that pass up to 10, 12 millimeters. So our disposition for this patient: our diagnosis is pyelonephritis or kidney infection. Treatment is antibiotics, and we have to gauge whether inpatient versus outpatient. Typically, males will have inpatient antibiotics just because of their anatomy. It's very difficult for them to get urinary tract infections. And in women, outpatient antibiotics typically are warranted unless the patient clinically is very sick, high white count, high fevers, abnormal vitals, high tachycardia, any vital sign derangements that we feel uncomfortable sending the patient home, or if patient's not a very reliable resource or historian, sometimes we want to put them in for IV antibiotics just to make sure that they're able to get their antibiotics and we know that they're going to get better in the hospital. So documentation should focus on the conversation on follow-up with urology, what to return to the ER for. So this is our medical decision-making component, and it's very important to document why we chose inpatient versus outpatient, what we said with the conversation with the patient about following up with urology, and what symptoms to return for, whether that's high fevers, if the pain increases and is not controlled at home, or any symptoms that may be concerning to us that the physician wants documented.